Assalamu alaikum. Good afternoon, everyone. Welcome to our first conference about advances in breast cancer management. First of all, I would like to thank the scientific and organizing committee for their enthusiasm and their effort and putting their time in making this conference happen. And also, I would like to thank the speaker, moderators, attendees for active participation and for accepting our invitation. I cannot forget the drug companies that used to support our activities generously all the time, and namely Lilly, Pfizer, Novartis, MSD, and AstraZeneca. And of course, behind this big work is a team from organizer and manager who manage this activity very well. And without their help and great support and amazing work, this conference would have not been happened. This conference will be for 2 days. Today will start in a minute and will close at 6 p.m. We'll be having 2 sessions, and then in between we'll be having satellite symposium. 2 will start a little bit earlier. We'll start at 9 and then we'll close at 4 p.m. And the first session today about early breast cancer, hormonal positive. We're going to listen from eminent and distinguished speakers and moderators. And we are willing to accept your question and participation from the attendees, of course. So the first session will be moderated by Dr. Amina Tijani and Dr. Abdullah Tuwergi. Dr. Tuwergi is a consultant of adult medical oncology at King Fahad Hospital in Riyadh, and Dr. Amin is a consultant of adult medical oncology at King Abdullah Specialist and Children's Hospital. Dr. Abdullah and Dr. Amin, please, the floor is yours.
Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh.
Yes, go ahead.
Yeah, thank you so much, Dr. Nafisa. Thanks so much. And I would like to thank really everyone, organizer for being part of such activity. I would like to welcome everyone who joined us today. And the main focus of today's session would be on the hormone positive breast cancer and touching the early stage disease. I will be honored to co-chair this meeting also with Dr. Amina Tijani. Dr. Amina Tijani is medical oncologist at National Guard Hospital. With this, I think I would like to start with introducing our first speaker. I always like to introduce Prof. Ahmed. Dr. Ahmed Saadeddin is a consultant education supervisor at Adult Medical Oncology in King Abdulaziz Medical City at National Guard Hospital in Riyadh. He's a professor of oncology at King Saud Abdulaziz University Hospital. I always a big fan of his talk, and I always like the wisdom of his talk, which always comes between the lines. So Dr. Ahmed, he will try to focus on one of the important and exciting topic for the last few years, which is the role of CDK4/6 inhibitor in early stage. We know those agents has been quite available for the metastatic disease, and really we have great advances when it comes to advanced stage disease. But the question is when to use this agent in a more earlier stage, and specifically in the adjuvant. So Dr. Ahmed, he will highlight this point. The mic is yours.
Thank you, Dr. Abdullah, for this very kind invitation. And thank you, Nafisa and the team for organizing this event. Is my screen, seen for everyone? Hello?
Yeah, I think there is some, I can't see the screen very well.
Please close it and reopen it one more time.
Yeah, I think there is some issues. So if you can close it and restart, Dr. Ahmed, it will be maybe more clear.
Let me try again. I don't know what happened to the whole thing.
You can stop share and then you can reshare.
So you can see.
Yes, yes, quite great. Just to open the, yes.
Okay. Okay, so thank you again very much for this nice introduction, and thank you, Abdullah, always for your nice words, and thank you, the organizing committee, for the invitation. I've been given this task: where do we stand with CD46 inhibition in early breast cancer? An important question which we all face in the clinic. Now, you know, these are the contents of the things which I'm going to fly through over the coming maybe 20-25 minutes. Why CD46 in hormone positive early breast cancer? Why is it in breast cancer in general? Because we have known for a very long time that even with AI, which is supposed to be a little bit better than tamoxifen, we are still in the metastatic setting, used to lose a lot of patients during the course of disease, whether it's HER2 negative or HER2 positive, although HER2 negative disease used to do better. But there was a clear unmet need to improve on that. This is a topic which will be addressed, I think, extensively by colleagues in the future sessions. What did we achieve with endocrine therapy in metastatic setting? Not too much. PFS of usually 10 months, and in some data it has been pushed up to 15 when you have used combination of fulvestrant plus AI in one study. So again, the unmet need was very clear in metastatic till this class of medication came, which we all know a lot about it, inhibit the CD46, arrest the cell cycle, and cause tumor regression. And this has been proven in the metastatic setting in the first and second line to improve PFS and overall survival, as we have seen, happily in MONALEESA 7, MONALEESA 3, and MONARCH 2 recently. So clear, effective class of medication in the metastatic setting, which have improved survival, things which we would love to see, but we rarely do. Now, as we have been doing all the way in breast cancer for colleagues who have been, like me, for more than 20 years in this field, when we have something working in the metastatic, we try to push it out to the earlier phase, neoadjuvant and adjuvant. So where do we stand with that? Let's start with the neoadjuvant setting. And why neoadjuvant? Because, people who knows me, they know I like this slide from Prof. Mark Naples. We don't want to be blind. If you can see something, try to put the glasses and have a look. Why not? So this gives you the opportunity for in vivo selection. You know where are you going before you chop that tumor away and you become blind on the response. It's a potential model for productivity and for biological developments of medications and so on. So I think it's a chance. And as time passed by, we have learned that this is a very important, stage of the disease course where we can learn a lot from. And we actually started to do this. But the problem was, the anecdotal data from endocrine therapy in the neoadjuvant setting is very poor. Pathological rate of around 2% in 4 months, 5% in 8 months, and it jumped up to almost 18% when neoadjuvant hormonal have been used for 1 year. So what we have learned that actually longer is better for response rate and eventually breast conservation, which is one of the main issues we always think of when it comes to neoadjuvant setting. Although, I still believe that in the future we will see a better selection and better survival, but maybe we need to learn how to do it better. And we are in the process, by the way. This is the plethora of the trials of using CDK4/6 inhibitors in the neoadjuvant and adjuvant setting, and I will go through them very briefly. We don't have a lot of data available which can change our practice yet, but I think things are coming. The Neopath study, the Neopath study was a phase 2 randomized non-comparative study where after establishing diagnosis of luminal disease, the molecular profiling is being done through Prosigna, and luminal A and B are randomized, while non-luminals, they go for chemotherapy. And after randomization, they go either to letrozole plus balbo or chemotherapy. So we are here comparing chemotherapy, which used to be our standard practice, to something which we think is as good as chemotherapy, which is AI plus balbociclib. I think this is pushing the question a little bit further. What did we know? That the residual cancer burden, which reflects efficacy, was 50% reduced with the use of balbo plus letrozole compared to chemotherapy. That was really very interesting. In the final analysis of Neopath, the RCP was 4% in the combination of balbo plus letro versus 8% in chemotherapy. Impressive. The pellet is another phase 2 study, but here using balbo plus letrozole. This is a non-comparative study. It actually sort of randomized between either letrozole alone for 14 weeks, before surgery, or balbociclib alone for 2 weeks, followed by 12 weeks of combination, or 2 weeks of letrozole followed by 12 weeks of combination, or indeed 14 weeks of combination, then surgery. And the primary endpoint was actually Ki-67 change at week 14, which is very interesting endpoint. I've been trained at the Marsden with my dear mentor, Prof. Evans, who always thought that Ki-67 after endocrine therapy reflects endocrine sensitivity. So this is another study which actually addressed that question again. We are waiting for the data from that one. Neomark, Neomonarch, again, is another pre-surgical study, which is addressing a lot of important issues related to the core biopsies, where you do randomization after core biopsies to either AI alone or Abema alone or combination. And for 2 weeks, then after 2 weeks, you do another core biopsy and you start them into Abema plus AI using anastrozole and this one. And after 14 weeks, you do another biopsy and you do surgery. So here we are, I think, waiting for a lot of biological data as well, on top of efficacy data, and whether Ki-67 and other things will correlate with the outcome of this combination. And there is, the data so far are in favor of using the combination to having Ki-67 come down to less than 3% at 2 weeks, which is extremely important. So again, whether you use it alone or in combination, using Abema was the key factor of actually reducing Ki-67. So you started to get hint that maybe endocrine therapy alone in the neoadjuvant setting maybe is not enough, and CD4/6 can add something to that platform in terms of response and complete remission. The third study, again, phase 2, recruiting with the other drug, which is ribo this time, again using either hormonal alone, using ribo at the usual dosing, 3 weeks on, 1 week off, 600 milligram, or actually using continuous dosing of 400 milligram, which I like very much personally for reasons I'm sure you understand. I don't believe very much in actually interrupting the CD4/6 if you can do without it. So again, this is a very interesting study, and we are all waiting for data to come out. We have been very actively involved in this international neoadjuvant study, phase 3, where OncoDX is being done, and if it is less than 31, people are recruited. More than 31, they go for chemotherapy. We start with, using fulvestrant for 4 months. In premenopausal, we add LHRH, and we carry on if there is a response to randomize to either fulvestrant alone for another 4 months, so total of 8, or we add palbociclib, after 4 months, and then they go for surgery. And we have the chance to publish this abstract recently. Basically, our conclusion was that a score less than 31 allowed selection for induction neoadjuvant hormonal therapy without loss of chance, with no progression rate. Our response rate was 96% between CR and PR. And there was no significant correlation between recurrence score and response to neoadjuvant hormonal therapy. There will be more publication of this data, which I think the first phase 3 trial I'm aware so far, which addresses this point. Sorry, I need some. Okay. What about adjuvant therapy? We have some data here. Not very pleasing, but basically 2 main trials, Palace and Penelope study. The Penelope is not yet reported. It actually compared between carrying on with adjuvant hormonal therapy as you usually do versus giving palbociclib in the adjuvant setting with the hormonal therapy 3-1 schedule. And the secondary endpoint, the primary endpoint is invasive disease-free survival with a lot of secondary endpoints. Interesting study to see the outcome. What we have the outcome from this study, the Palace study, recently published, adjuvant endocrine therapy in early breast cancer. This is the interim analysis, the second one. And this is the design of the study. So early luminal breast cancer, including pre and post-menopausal. They have actually put some men in it, which is good. Primary chemotherapy was allowed. Randomization between 2 years of palbo plus the usual period of endocrine therapy versus endocrine therapy alone. And again, very similar to the previous one. The IDFS, invasive disease-free survival, was the primary endpoint. And there is a lot of stratification based on pathological stage, clinical stage, and so on. What did we find? First, let's go through some, epidemiological data from that study. As you might notice that the less than 50 years of age were almost half of the patients, which to me important because it actually reflects to what we see in our clinics, more younger people. Very few male, but at least they are there, 0.6-0.7%. Pre and post-menopausal were almost equally divided between the two. And yes, very few Asian and Blacks, but you know, that is the study countries. Most of the patients were stage 2 and 3, which is good. T2 and T3 and 4 again were the bulk of tumor source, you know, and as well as nodal positivity was in the most numbers of patients as well in both groups. And grade 2, 3 also were good numbers. So it actually sort of mirrors what we see in our daily clinics, and this is reassuring. What was surprising to me that the rate of mastectomy was 62%. You know, I always hope that we'll see less numbers of mastectomies in breast cancer. I'm very allergic to these numbers when it comes to you know, breast amputation. Nothing unusual about you know, adjuvant radio and hormonal therapy. That is important, and as well to read the data or the results in view of this. Only 32% or 32.3% actually have completed valvosectomy, 1/3. So 2/3 did not. And 42% discontinued valvo early, you know, due to adverse events, non-compliance, name it. But, you know, less than 50%, almost 50%, have discontinued the drug early in the course. While you cannot say the same about endocrine therapy. Most of the patients continued full course of endocrine therapy. What did we find? As you can see, impressive results in a negative way. You know, you can not differentiate between the two colors almost when it comes to the primary endpoint, invasive disease-free survival, or distant recurrence-free survival, which was a secondary endpoint. Clear negative study. You know, as you can see as well, that hormonal therapy itself, they have actually done well at 36 months. Could we, you know, sort of find anything which might have made a difference in favor of giving valvo? The answer is no. You know, all the lines crossed one, and one cannot really choose patients to say these patients will potentially benefit from the medication. And side effects, as you might expect, were, you know, a little bit more when it comes to neutropenia and fatigue compared to the endocrine therapy alone, but nothing unusual. I think this is a common knowledge for most of the audience at this point. So the conclusion was that at this second interim analysis, the addition of 2 years of adjuvant valvo to adjuvant endocrine therapy did not improve invasive disease-free survival. On this basis, this regimen cannot be recommended in the adjuvant setting. Long-term follow-up, you know, and correlation with other studies are ongoing. So this is the conclusion at this point. You know, now, you know, if you have much more aggressive disease, you know, grade 3, 16 out of 18 lymph nodes positive, T4 disease, where do we stand with such cases? I think maybe we can discuss a little bit more.
Dr. Ahmed, we have probably 2 or 3 minutes more.
Yeah, I'm not actually. That's it. That's, you know, that's my conclusion. So my conclusion to this very important, simple questions, that in early breast cancer luminal time, CD46 inhibition, it's not yet approved in the adjuvant setting, and actually the data are not promising. I think we need to have a better selection of patients who might benefit from these 2 years of CD46 inhibition. While in the neoadjuvant setting, the CD46 inhibition might become a standard of care for, maybe, again, not everybody, but patients with node-positive disease, aggressive disease, and so on. I think more data are needed to conclude in these issues, but extremely important topics to be looked for in the coming few years with the literature on the outcome of ongoing trials. Thank you very much.
Thank you so much, Prof. Ahmed. Now I will hand over to Dr. Amin to introduce our next speaker.
Amin, you are muted.
It is my pleasure to introduce Dr. Athar Sayed. He's a consultant medical oncologist. He's specialized in breast cancer and oncology. Dr. Athar will talk about does 21